So we're hoping with our session today to talk to you a little bit about the work that's been happening in Wisconsin related to community health improvement work, and share with you both some tools that we have used, link you with some national tools that we have used, and have a case study from one of our communities to talk about what they're doing. And our focus really is on moving into the implementation phase. And we'll talk a little bit more about this, but I think a lot of times people get to that point and say, how do we move from choosing priorities into developing an action plan that works for all the players? So we'll tell you a little bit about the approach that we've taken and share that with you. Here briefly are the objectives for the session. First, to help you understand a little bit, at least from our experience, about how to keep that momentum going forward from your assessment into your implementation. Then to really introduce you to one specific plan that we developed that we think might be useful to other folks beyond Wisconsin, the template implementation plan that was mentioned. I'll try to connect for you how our template implementation plan taps into Healthy People 2020 and some of the resources that are there that might help your community with implementation. To start with, a little bit of background from Mandy.
Okay, thank you, Julie. I'm going to talk a little bit about the history and the background. In 1993, the Wisconsin State Statute required our health department to develop a community health improvement processes and plans, or CHIPP. There kind of went a 12-year gap in Wisconsin, although a lot of the hospitals, or in some of the areas, were reporting community benefits. They were still working on, some were mandatory, some were half mandatory, some were half voluntary, and in Wisconsin, or WHA, was going to be 100% voluntary. So when the Affordable Care Act came about and the IRS requirements came about in 2005, that's really when we started looking at community benefits and community health needs assessments. WHA knew that public health department was very strong and historical in the participation of community health improvement work. We also knew that WHA could bridge the gap between hospitals and the public health with the IRS requirements. So I'm not going to go through all of the timeline, but some of the highlights that most of you, if you're doing community benefits, are familiar with was one of the initiatives in 2005 with Senator Grassley for the tax exempt status, which brought about a lot of the scrambling in the last few years. 2005, we also created a task force team, which consisted of a lot of our Wisconsin hospital leaders and some of our large systems, along with our rural hospitals. WHA then created and went through in 2006 with our launch of our community benefits. We came out with all of our stories. We had public health officials at the table, and we were charged with the what counts piece. And we paid most of our attention on what counts and all of the stories, so we were able to tell the stories and put stories with all of our dollar amounts. Then moving forward, we came into 2010, which WHA was approached by the population health along with public health, and we came together to start talking about a grant that they wanted to apply for, and they really wanted hospitals at the table. Community health needs assessments were becoming more critical for all the hospitals. And our hospitals in Wisconsin wanted a tool that was cost-effective, more or less free, and something that they could use to really get the ball rolling because they were kind of scrambling when it came about. Some of the challenges that we faced when we all came together was in 1993, they were all working on CHIPP. We were working on community health needs assessments. So that terminology right there was kind of a gap that we found in hospital, and we're still kind of dealing with it today when we have everybody at the table. So the terminology was a little bit different, but we knew that we had to still keep going forward. Another problem that we faced is in 93 when public health was mandated, they were all going forward, but at the time the hospitals really weren't on board yet. And so a lot of bridges were burned, and so what we needed to do was kind of put the hospitals back at that same table when we started going for this grant so we could start getting the grant and the people together. One of the requirements of the grant were to have a public health and a hospital at the table in order to get that grant. Hospitals also operate very much as a business model orient. where our public health seems to focus on a lot of the processes, and it kind of gets bogged down, and our hospitals in the state are very action-oriented. And finally, with the fine came our community health benefits and community health needs assessment. They wanted that free tool. That was a huge motivator for public health to come right back to the table for us, which helped us out a lot. And we were able to get a jump start. WHA really looked to public health for this. They had the CHIPP tool that worked. They had it in place. They had the wheel created, and our hospitals wanted that free tool. So with that, we went and started working with the templates and really focusing on how we could change it from not just community or public benefit, or excuse me, public health oriented, to really start transitioning the terminology to look more into the hospitals and get the hospitals back at the table. And so that's kind of where we are today. And I'll pass it back over to Julie, and Julie's going to talk a little bit about more of the grant itself and where we are with that.
Great. So let me tell you a little bit about the project that we've been working on, starting by talking about the title of it, the Community Health Improvement Plans and Processes Infrastructure Improvement Project. First of all, I just have to apologize right up front, because since we've started this collaborative, we try to not use those acronyms anymore. I try to never say CHIPP anymore. And we try to use very neutral, easy to understand language about this work that we're trying to do together. So it is in the title of our grant, and we're sort of stuck with that, but I want to apologize for it. I also want to point out, for those of you who've worked closely with health departments, they often talk about CHIPP and PHAB, and CHIPP is the Community Health Improvement Plan. And in Wisconsin, you notice we have 2 Ps in CHIPP, and that's because we really focus on the ongoing process and not so much do an assessment, write a plan, and there you go, we'll see you in 5 years, but really continuing that momentum into implementation. So it's not a typo when we have 2 Ps in CHIPP. And then finally, the Infrastructure Improvement Project, really that phrase gives you a sense of the flavor of what our project is, which is because health departments, as Mandy mentioned, have been doing community health improvement work in Wisconsin for about 20 years, there was something of an infrastructure in place. There certainly were practices and history and documents in place. And what we wanted to do was to see how those practices could be strengthened, how we could look at the literature on this type of work and move people towards best practices in community health improvement work, and really identify the gaps and try to meet the needs that people had for that. So we received, fortunately, a 3-year grant from the University of Wisconsin, and the core partners that are listed there are the people who are either funded, which is my organization, the Association of Local Health Departments and Boards, and the University of Wisconsin. Those are the 2 core partners, and the others wrote letters of support and serve on our core advisory group. So you can see it's really got the right people at the table, and we're trying, although we aren't always perfect at it, to demonstrate at a state level the kind of collaboration that we're encouraging at the local level between particularly hospitals and health departments who are both mandated to be involved in this type of activity. So this is what our purpose of our project is, and we're about 2 years into our 3-year project, is to create a collaborative model, so a model that works for all the partners, to improve the health of the community and give some specific tools to carry out that model. The steps that we've gone through, we started by doing an environmental scan and needs assessment. So with the scan, looking at what's already in place and what are the resources that are available. And then the needs assessment, talking to the various stakeholders, not just hospitals and health departments, but we talked with United Way, and I know some other folks around the country work very closely with their United Way in this work. Our extension office, who often helps to facilitate, the school systems. So we have a variety of different players that we talk to them about what do you see as the needs for local communities. And then based on that assessment, we developed some resources to help fill the gaps or strengthen the practice in local communities, both human and written. In terms of human, we took a team of people through a leadership institute, and they're providing technical assistance to our pilot sites. In terms of our written resources, I'll review those in a second and show you the website where they are that you can take a look at. Where we are at now is testing the resources in 10 pilot communities around the state. And the Ashland and Bayfield partnership, who will speak in a minute, is one of those 10 communities that are testing these tools and giving us feedback on whether they help them in their practice and how they might be improved. And then at the end of our grant period, we'll fine-tune them based on the feedback from the pilot communities and disseminate them statewide. We chose our pilot communities to try to get a variety. We wanted to see different mixes, different relationships between hospitals and health departments, some that were rural, some that were urban. We wanted to be sure that the resources that we created worked in a variety of different settings. And actually, in the case of the Ashland and Bayfield partnership, they're the one that we chose that's a 2-county with 1 hospital. We have several of our pilot sites that are 1 county with 2 or more hospitals that are involved. So one of the first things that we did was to try to create a shared model of what we mean when we talk about community health improvement. And I thought of this early this afternoon when the keynote speaker was talking about having a common vocabulary. And when we had a meeting, it's sort of historic, we all still laugh about it now, with all of our stakeholders, about 20 people from different sectors around the room saying we need to have a model that we all share. At one point, Mary Kay Grasmick, who's also from the Wisconsin Hospital Association, and Julie Willems Van Dyke from the university looked at each other, and they could tell they were not talking about the same thing. And so we literally paused the agenda and said, let's figure this out. What do you mean when you say we need a model, and what do you mean? And we were talking about 2 different things. So we created a model that has 2 parts because both were really important. Talking about what is it that makes a community healthy, and how can a community become healthier. And we committed ourselves, and here's what I mentioned earlier, to use everyday language in that material. And the document itself is 3 pages long, very brief, very visual, intended to be something that you could hand to a stakeholder in your community and say, I'd like you to be involved in this, and this is what it's about. So it takes all of that verbiage that we use in our day-to-day work out of it and puts it in everyday language to say, here's what's shaping the health of our community. Here's what we could do about it. We'd like you to be part of it. So it's sort of written elevator talk. So let me give you a glance at that model. This is a simplified version of the part that talks about what makes a community healthy. I assume many of you are familiar with county health rankings. And so our academic partner at the university hosts the county health rankings and roadmaps. So this is very similar to their model. And what's different about it in terms of how we used it in Wisconsin is we took the health priorities from our state health plan and plugged them in there. So we really married those 2 models. And in our needs assessment, we had seen that a lot of communities were using one or the other or trying to figure out how to do both. So we tried to marry them together. So for example, where our state health plan talks about chronic diseases, we have that under morbidity. And where it talks about smoking, we have that under health behaviors and so on. So people can see how that list of issues that as a state we've decided to work on fits in this causal model that moves us from talking about outcomes into the factors that we can influence to shape those outcomes. Then the second half about how a community can become healthier is a circular model about community health improvement. And you've probably seen many like this because, frankly, I just looked at all of them and took the best of all of them and put them into one diagram that's easy to understand and takes you through that assessment, prioritization, action planning, implement, and evaluate, that constant cycle that we do to help improve the health of our communities, with collaborating with stakeholders in the middle and engaging the community at large, happening throughout that cycle. So let me just mention. These are the different resources that we've created and are piloting in our 10 communities. Probably the backbone of it is the guidebook on improving the health of local communities. And it has a section for each of those steps in the improvement cycle. And again, I went to many of the best resources that are available in the country, probably ones that you use, and tried to synthesize it down to something that is easy to pick up and run with. So it's very much sort of a checklist format, But within the document, there are a lot of hyperlinks, so you can take the simple at-a-glance checklist, but if you want to drill down deeper, it's at your fingertips there in terms of linking to it. The other thing that we did in that guidebook, and it's been very well received, is throughout each of the action steps, we cross-reference the IRS requirements for hospitals and the requirements for local health departments, both in our state statutes and for those that are pursuing voluntary national accreditation. And so people have found that helpful as you're looking down a list of maybe 5 things you should do in terms of prioritization. Ooh, this one I'm actually required to do. So let's not skip over that and say I'm not sure that will work, because it's a requirement for our organization. The other resources there you can see listed, and there's the website where you can find all of them, and you should have a copy of these slides available to you if you didn't get a chance to jot that down. Today we really want to focus on the resources that we created to help people move into implementation. I saw some head nodding even when I mentioned this at the beginning, that a lot of communities struggle when they move into implementation. They spend a lot of time and energy on the assessment, and people are frankly kind of pooped out by the time they're done. As well as, that can be really dry for a lot of people, the assessment part, the data, the prioritization, and there's some attrition just because of the nature of that. So how do we then keep that energy going, moving into implementation? And the guidebook talks a little bit about that, but the other quotes here are things that we heard in our needs assessment. So a direct quote from someone, we want assistance on how to narrow down the focus to something manageable, something we can do here now. So I think, again, our keynote speaker said, well, let's fix childhood obesity. You're not going to do that in 3 years. What can you do in 3 years in your community with the resources that you have? And you can see, again, health departments and hospitals both talking about how that would be helpful to them. So our answer to that need was to create, in part, was to create a template implementation plan for people to use to give some structure to action planning. How do you go from that very broad concept, drilling down further and further into things that are doable at the local level, but tracking the right information that you need to have? It's structured to guide people towards evidence-based strategies and to encourage collaboration, and I'll show you where that shows up. And again, we looked at the requirements from the Affordable Care Act and the Public Health Accreditation Board to assure that the tool would meet the needs of those 2 partners in terms of what they need to have in their implementation plan. As was mentioned at the beginning, you do have a copy of the entire plan. I'm going to show you bits of it just to demonstrate the points that I was making here. So we start with a priority area, and I chose nutrition and physical activity because probably like many of you, a vast majority of our local communities choose that as a high priority to work on. And they may get as far as a goal, like implementing policies that help improve diet and physical activity, but then sort of where do you go from there? How do you drill down? So the next level that we added there is performance measures. So both short-term and long-term, what are the things we're going to track that we might see changes 1 year, 3 years, 5 years, that we can put in our report card to the community that we're looking to see whether our efforts have made a difference? And again, I thought of this during the keynote presentation, talking about a shared agenda, which is the top half, and shared measurement, which is the bottom half, that all the partners are looking to accomplish the same thing and tracking the same thing. From there, we kind of go into the nuts and bolts of an action plan. So first, writing an objective that's smart and measurable. And then the background part, the 3 things listed in the background on the strategy are required for health departments that are seeking accreditation, but they're just good practice for any community, whether or not they're seeking public health accreditation. One is to look at the source, and there are some great strategies that come with an entire toolkit that make it easier for your community to know, where do I start? How do I do this? The second is we encourage you, whenever you can, to cite the evidence base. Not only does that help, again, to steer you towards using evidence-based strategies, but it's good for accountability to your organization or to the community at large, that you are choosing strategies that you have really good sense will make a difference in your community. And then whether or not it's a policy strategy. So just to think about that, because that can often be a way to leverage really broad and deep change in the community. And then the bottom part is sort of a standard work plan in terms of action steps, target dates, and so on. But the part I wanted to highlight is the column about who is the lead person or organization. Because here's where we can have a collaborative action plan. And this was addressing one of the concerns that we heard from folks, particularly in hospitals, saying, I need to be able to report, here's what I agreed to do, and here's whether or not I followed through on it. But if we all have one action plan, it gets a little bit lost in there. So by having the accountability by name or by organization, it helps you to see where everybody's contributing their part towards that shared goal together then. And the last part here is just linking your local plan with state and national priorities. Again, for health departments that are seeking accreditation, this is a requirement, but it's a great thing to do. You can see our state health plan there, cross-referenced to the 3 objectives that we used. But the Healthy People 2020 and the National Prevention Strategy, whether you come up with your own strategies and then link to them or start there, because they also have very specific and helpful ideas about the kinds of strategies that have been shown to be effective in local communities, the kinds of things that are being recommended on the national level. And in terms of Healthy People 2020, I'll try to tell Emmeline's story for her since we don't know where she is. As I was creating this tool and I was linking our objectives to the Healthy People 2020 site, I started wandering around that website and found so many useful tools that help at the community level. Both information about evidence-based practice, national targets for very specific measures. So I would really encourage you to take the time and take a look at what resources are there. In addition to that, we've listed some other resources here. Are many people in the room familiar with the Community Guide or What Works for Health? So those are the 2 that we particularly rely on. What Works for Health also came out of the University of Wisconsin and now has been linked to the County Health Rankings and Roadmaps site. But they reviewed, I think, 6 different national sources that have evaluated evidence-based practice and combined them into one place, which keeps you from having to go to quite so many places to get that guidance. But again, I would encourage you to use that as a resource for yourself. All right, so that's pretty much the overview that I had of the work that we've been doing in Wisconsin, and that one particular tool that I hope may be helpful to you either specifically or conceptually in your work, and some links to some additional resources that may help you with your work. I'm going to turn then to our case study from one of our pilot sites to talk about what they've been working on.